Good afternoon. Thank you, Dr. Abdullah and Dr. Rosano, for the invitation. So, I have no disclosure, so I will talk about obesity in general and then the risk of heart failure and how are we going to tackle weight loss and what are the impact of weight loss on cardiovascular disease. We know that obesity is very prevalent worldwide and the prevalence is increasing with time, but you can see data from USA that if by 2030, around 80% of the population, they are either overweight or obese. Only less than 20 to 1% they will be normal or underweight. So obesity increases with time. This is from different regions worldwide, from 1975 till 2016. And you can see the GCC, the Gulf region here, actually is even equal to North America in the prevalence. So it's high prevalent here. And on the right side, you can see that one important thing that increased tremendously over the years since 2005 is importing unhealthy food to the Gulf region. If we compare the Gulf region countries, this is from World Health Organization, we can see that the prevalence in Kuwait of obesity is around 38%, and they rank 11 worldwide in obesity. And in most of the countries here, it's between 27 and 38%. So the prevalence is very high in our region. The second thing, we know that obesity is related with diabetes, and we know diabetes has its impact on cardiovascular disease, but at the same time, if we take diabetic patients with higher body mass index, they increase the hazard ratio for heart failure tremendously, while hemoglobin A1C has an impact on cerebrovascular disease, and duration of diabetes has an impact on coronary artery disease. And if you can see here that patients with higher body mass index, they have a significant increase, exponential increase in the hazard ratio of heart failure. So it's not only obesity affects atherosclerosis, cardiovascular death, and atrial fibrillation, but there is a strong association with higher risk of heart failure. And there are multiple reasons why obesity increases the risk of heart failure. From the myocardial fat deposition, insulin resistance, adipocyte dysfunction, inflammation, they all alter the metabolic profile and increase the additional cardiovascular risk that may lead to heart failure. In addition, obstructive sleep apnea, obesity hypoventilation, just decrease mechanical effect of the abdominal fat and chest wall, increased intraventricular pressure that may lead to increased intraventricular filling pressures, hypoxia that will lead also to heart failure, especially right-sided heart failure. So, obesity increases the risk of heart failure. So compared to overweight and normal, so the higher the body mass index, the higher the obesity, whether in men and women, you can see in red here. And if we compare between preserved ejection fraction and reduced ejection fraction, we can see in preserved ejection fraction, it is strongly correlated with the incidence of HFpEF with higher body mass index, more than heart failure with reduced ejection fraction. Also, obese women, they have a tendency with time to develop heart failure with preserved ejection fraction, while obese men, they have a higher tendency to have heart failure with reduced ejection fraction. We know that obesity may lead to insulin-resistant endothelial dysfunction, vascular inflammation, oxidative stress. These are the pathophysiologic mechanism of heart failure with preserved ejection fraction. So this is why they are very correlated between each other. And obesity increases the risk of heart failure hospitalization, whether in heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. Even from the DELIVER trial sub-analysis or from the DAPA-HF, the higher the body weight, the higher the risk of heart failure hospitalization. So obese patients with heart failure, they have higher symptom burden, lower exercise capacity, higher rate of hospitalization, and deranged hemodynamics. They are more having diastolic abnormalities, more right ventricular dysfunction, more increase in cardiac filling pressure and wedge pressure, and more relative increase in oxygen consumption that will lead to worsening functional capacity, higher symptoms, and lower quality of life. So what is in the impact of weight loss in the outcome in heart failure? What is the impact of lifestyle changes, bariatric surgery, and pharmacological therapy? We know recently medical therapy has gained a lot of attention in decreasing weight. We have a lot of evidence in bariatric surgery. Weight loss with bariatric surgery compared to no surgery tremendously decrease MACE in these patients. Second thing, bariatric surgery compared to lifestyle decreases weight and decreases waist circumference more than lifestyle modification. And not only that, but surgery compared to lifestyle modification reduces the risk of heart failure. Every 10 kilograms, at 1 year reduction, they have increased risk of heart failure. So the more we lose weight in 1 year, the lower the risk of heart failure in these patients. This is from the Swedish National Patient Registry of around 47,000 patients with obesity, with the primary diagnosis of obesity between over 11 years. Half of them were underwent bariatric surgery, and the other they didn't underwent surgery. We can see that survival probability is higher in patients who underwent surgery. Also, surgery in a pooled analysis reduces significantly the risk of heart failure in these patients, as well as in heart failure with reduced ejection fraction undergoing bariatric surgery, it improved their ejection fraction. Not only that, but improved the quality of life. New York Heart Failure Association, LV mass also has been reduced at 6 months post-surgery. And this is from magnetic resonance imaging and from echocardiography, showing that not only LV mass, but all LV and diastolic volume has been reduced. Also, this is a meta-analysis of different studies, including weight loss with bariatric surgery or with diet alone, showed there is a decrease in heart rate, decrease in mean arterial pressure, decrease in right atrial pressure, wedge pressure, and pulmonary artery pressure. And this mechanism of reverse remodeling following bariatric surgery could be hemodynamic effect or metabolic effect. Metabolic because we are decreasing systemic inflammatory response, reducing CRP, improving insulin sensitivity, but on the other hand, hemodynamics leading to reduced blood volume, improving LV stroke volume, and cardiac output that will lead to decreased LV size, decreased mass, decreased wall thickness, and decreased LVS. So most probably it's a combined metabolic and hemodynamic hypothesis. Bariatric surgery in a study of patients, of 500 patients, 24, compared to patients who didn't undergo bariatric surgery. This is a study where showed pre-surgery, the incidence of heart failure, hospitalization, and post-surgery. So there is a tremendous reduction of hospitalization for heart failure in patients who underwent bariatric surgery in these patients. And these patients, they have pulmonary artery pressure monitoring like cardiomams. You can see just the pulmonary artery pressure reduction just tremendously after bariatric surgery. We have different types of bariatric surgery. Some are restrictive procedures, some they are minimally invasive procedure nowadays, and there are the large malabsorptive procedures, as well as the RO-NY gastric bypass banding, which are more extensive surgeries. We don't have a lot data about the less invasive surgery on the long term. Most of the trials were on larger extensive surgery, and we know the risk of surgery in these patients may be high. So this is one of the limitations. But at the same time, there are medications has been used in diabetes, and they are now being used in weight loss, like semaglutide. It has been published recently in the heart failure, in the European Society of Cardiology, the STEP HFpEF trial, using semaglutide. So in patients over an AF of more than 45%, with the body mass index more than 30, with heart failure symptoms, and functional heart class 2 to 4, in 13 countries, giving them either semaglutide 2.4 grams versus placebo, following them over 52 weeks. And actually, it has been shown to reduce that body weight significantly, as well as the mean change in KCCQ score, meaning that the quality of life of these patients, and it didn't differ between whether 45 to 49 on different ejection fraction. It was the same impact. Similarly, other than body weight, there was a significant 6-minute walk test and in the composite endpoint. Not only that, the adverse events, even though they were more in the placebo group than the semaglutide group. Only we have increased gastrointestinal adverse events with the semaglutide group, but mostly they were cardiac events in the placebo group of these patients. So it was effective. There are several trials before with liraglutide in 2017 and 2018 with the LIVE trial and the FIRE trial that showed reduction in weight in heart failure with reduced ejection fraction, but there was increase in heart rate, as well as there was a higher increased risk of cardiac events. So this is why in heart failure with reduced ejection fraction, we don't have anything up till now studies that show significance on any significant on primary outcome of these patients on cardiovascular disease and cardiovascular risk. Similarly, the FIGHT trial, and there are ongoing trials with tirzepatide, the SUMMIT trial, and the SURMOUNT MMO that will be published between 2024 and 2027 on in patients with heart that will assess obese patients with HFpEF on heart failure events, 6-minute walk, and the KCSU, as well as the SURMOUNT on MACE trial. So the take-home message is weight loss and risk of heart failure. Weight loss, especially via bariatric surgery, is associated with lower rates of incident heart failure. Higher body mass index is associated with a stepwise increase in the risk of future heart failure. Risk of HFpEF is particularly high among patients with obesity. Patients with obesity have higher rates of heart failure hospitalization, and the relation between obesity and death is still unclear. Weight loss is associated with improved symptom burden in patients with heart failure. We are still waiting ongoing trials to help to establish the impact of weight loss on clinical outcome. Thank you.